Hello and welcome to another K&K installment of Unfiltered Productions. My name is Cindy Kraft. We're here today with Sherry Teague, and we're going to flip the script a little bit from how we usually tee these up because I know today's topic has Sherry quite fired up. So I'm not about to steal her thunder. But what we want to talk about today is this whole count and visits, talking about count and visits. And you may have noticed, anyone who's seen our email addresses. They're very long. I know people have said, oh my gosh, that's a very long thing to type in for an email, but we chose it on purpose when our company began, going with value beyond the visit. And at that time, our focus and choice was driven about the whole therapy visit counting thing and how it was, everybody needed more therapy. Oh yeah, because it had a lot to do with how much revenue we were going to make and how we needed to be looking at care delivery beyond just a number of visits. Well, we know that day is done. PPS is over in its old form, and now we have PDGM. But this thing won't go away. This, how many visits, doing a visit, our commodity is a visit. So Sherry, when I tee you up by saying, okay, what is with the visit counting? What is the biggest thing that sticks in your craw when you hear this just ongoing discussion and debate that goes always back to visits?
Cindy, I'm beyond the word visit. We have actually, our email address, in case those of you that don't know, is value beyond the visit. We've always said that healthcare home care practitioners have some value that goes beyond just going and visiting a patient. We know that with a visit that there's costs associated with the visit. There's the mileage, there's the equipment that you may use, there's the hourly rate or the per visit rate of the clinician that may be going out to see the patient. These days are gone, folks. I hate to be the harbinger of old news, that counting visits is not how we get value in home health. That is not how we quote unquote make money in home health. And the fact that we're holding on to this so tightly, it just brings me back to when we did count visits to make more money, Cindy. And how many years ago did that go away?
Well, honestly, it went away in the year 2000, so over 20 years ago. That was the whole purpose of moving us off of essentially a per visit model to a prospective payment system. We had that residual piece about therapy that many still don't seem to understand was never meant to incentivize something. It was meant to cover the cost because therapy was not so much of a routine expense prior to 2000. There wasn't a lot of therapy going on. So they built that add-on piece to treat it just like another patient characteristic. If they needed this amount of therapy, then here's some additional revenue so that agencies could afford to provide it when necessary. Not this is how you increase your case mix weight by making more visits. So what's interesting to me though, Sherry, if you look at the difference between prior to 2000 and then those early days, visits for nursing took a huge shift. I mean, it was before that BID was celebrated, and BID right now is just like you swore in church. This nobody wants to do that. So why do you think, even with that kind of shift, why are we still talking about visits then?
Okay, permission to speak freely. This is an unfiltered production, and I'm going to upset some people. Counting is easy. We all learned to count when we were very, very young. We all learned, a lot of us learned from the count on Sesame Street. Ah, 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 a one balloon in the air. That was a bad impression. But that's exactly what we learned when we were very young. And the people who count beans, i.e. the money folks in agencies, they think that things that home care value can be translated into the number of something. Visits is something that they hooked on because of what happened with the legislation in 2000. When anybody saw that there was a $1,500 increase from visit 9 to visit 10, guess what? Everybody was getting 10 or 11. It's not a no-brainer. Now we're seeing the same conversation coming up, and probably what got me a little bit incensed is all I hear about is LUPA. LUPA management, low utilization payment adjustment. That means if you only see somebody a few times, you're not going to be paid for the entire 30-day period or 60-day episode. You will only be paid for the couple few times that you saw that individual. Agencies are obsessed with not losing that revenue beyond a certain visit number when if that's all you do, if that's all you manage, that's all you're going to make happen in your agency. If all you manage is visits, that's all you're going to make happen in your agency. Can I say that again? If
Hmm.
all you manage is visits, that's all you're going to make happen. And we have to have a full paradigm shift and get away from using the word visits.
Well, what I've never understood, Sherry, is regardless of LUPAs or therapy visits or any sort of connection to the reimbursement side, is it the intent of a prospective payment system to manage a patient for a period of time? So that that 30-day payment period is to manage them for 30 days.
Mhm.
And visiting is only part of that because it's not like we move in with patients. We're having very limited encounters, and I've said for years. I mean, the model is completely different than facility-based care in that when they're in a facility, they have 24/7 access to medical professionals. Maybe not me as an individual. I go home after a while, but somebody's always there. And in home care, medical people are not always there, and sometimes the patients are completely alone. So if I'm only viewing my worth as a clinician as the time I'm physically in the house, there are so many hours out of a 30-day payment period. A medical person isn't there. So what are we doing about that time?
And it's amazing, Cindy. You know, when I owned an agency in Florida in the 2000 from 2004 to 2014, I think, what was amazing to me is how patients that were closer and nicer got all the visits they needed or wanted or ever wanted to have in their life. The patients that were further and meaner barely got the number of visits that we needed to usurp a LUPA. That's just a fact of life. Patients that are more receptive to our care will allow us in the house. Patients that aren't will not. You know, and for me, it's always been an issue with therapy. You know, we're reading a lot, and you and I get a lot of contacts about therapy visits being managed to the point of death. Um, where the clinician's turning in an eval that has a request for 3 week 4, and they get back that good, thank you for your eval, but we're only going to give you 3 visits, and versus the 4 weeks of care that that patient requires, and that's all under some sort of cost parameter that they're trying to meet so that they make a profit. And please let me be clear: agencies have to make a profit to survive. You got to keep the lights on. You got to keep your liability insurance. You have to keep all the benefits you give your patients, the salaries you pay your patients. You have to make a profit in order to do that. I am not saying that you should not make a profit, but I'm saying it should be clear in every discipline why we're going into that house, why we're going out and physically being in front, and it needs to be a valuable asset that we're providing by going to that house. I'll give you a great example. In nursing, it's very clear. If a patient has a wound that's infected, the goal is to get that wound healed. Once the wound is healed, nursing will stop. Clear as day. Maybe the wound will be in a manageable position and visits will stop. Very clear. In therapy, it's a lot hazier. Is that a fair thing to say, Cindy? What
Yes.
is the goal to stop seeing that patient or take them off a caseload? That's the kind of conversations that we need to have. Maybe it would be valuable to organizations to ask your clinicians, why are you going out there today? And have that dialogue go in that direction versus, hey, I need 15 visits. Well, you got 2. That's kind of the conversations that we're hearing, Cindy. Do you have anything to add to that?
Well, I think that's an important one, Sherry, because on the therapy side, many therapists have been given kind of a free pass for the last 20 years. And
Mhm.
what I mean by that is more visits from therapy increase the revenue. So there
Right.
wasn't a lot of why are you going today? And I think we have to be, what we're saying is not the accusatory, why are you going? But having intelligent, patient focused conversations because I think as therapists, we were able to write through week 4 and everybody rejoiced. And to go from that to say now you get 3 feels very arbitrary and money driven and not patient driven. Do I think they should automatically get 3 week 4? No. Do I think it should just arbitrarily be cut to 3? No. I think good patient care is somewhere in the middle. And that's going to require conversation. Conversation about what are we trying to accomplish? What are the value of calling patients versus necessarily seeing them? Looking at things of telerehab and telemedicine. I think the pandemic opened people's eyes to what the possibilities are to manage patients when patients in the heat of the moment were not letting people in or buildings were not letting people in, and we said, oh my gosh, we have to figure out other ways to be able to get in front of them other than just physically. And yet there's still a resistance to that. There's a, okay, well, we'll try some of it, but we always have to look at these visits. And I think another incentive, since we're just going to bear all today, Sherry, is when you look at the number of visits clinicians generate when they're paid salary or hourly versus per visit. Then in
Woo!
my experience as a consultant and as a rehab manager in the past was when I go into an organization and they're telling me, oh, my therapist, they swear they can't do more than 4 or 5 a day, that they're basically going to drop dead if they do more than 5. And then it's you go to another agency and it's like these folks are cranking out 10, 15. I mean, just ridiculously high numbers per day. And then it's like, I don't even need to ask the question, but I'll ask anyway. Yeah, the ones that are going to die at 5 are usually your salary or hourly individuals, and your per visit people are off the charts in terms of number of visits they can supposedly do in a day. Again, we have to look at what are we incentivizing when this conversation continues to be visits are the value of how the organization views you, and visits are the value in terms of how we pay you. Now, you and I have had this conversation, not quite as candidly, but we've alluded to some of these things before and had folks get irritated with us about, well, we have to monitor visits from a cost perspective. What are your thoughts on that? I mean, we do have to measure something when we're looking at operations. And I'm sure as a former agency owner, you looked at the costs associated with visits, correct?
Right. And I'm just going to say this very candidly. You win some, you lose some. And at the end of the day, the way you manage that logistically and otherwise creates the profit. The interdisciplinary care, the discussion of teams and the ability to take a patient as a holistic thing versus a siloed thing where OT does one thing, PT does one thing, speech does one thing, nursing does another thing, that is an expensive model of care. To have those silos that don't communicate well. I think CMS tried to guide us in that direction with some of the PDGM language around interdisciplinary care. And I think that it needs to go further. I think that we need to come up with innovative ways to create value for that patient. And with value, we create outcomes. And notice, the sessions I've been to with you and Dee, Cindy, and when you guys ask what the number one goal of home health is to stay home from the hospital or to stay at home, people get that wrong consistently. We don't have people that are playing by the same game by the same set of rules, and that needs to change. We need to get away from having my discipline and what my discipline does. In my opinion, I mean, I think as a therapist, we want to do therapy things and we're best at therapy things, but there's a lot of other intangibles that we can do to create value for our team and to create that level of profit to keep the doors open, to keep an agency solvent.
And Sherry, this is unfiltered production, so we try to keep these time constrained because you and I could talk about this literally for hours. And it doesn't necessarily give you all the solutions. We're trying to give you food for thought because we're closing in on 2022 and there's still pushback and discussion from therapy about taking vital signs as part of
Oh,
visits. And I look at that and say, that's what we're talking about. Some folks may say, well, this is, I need to measure visits for cost, and visits is still an issue as this is how we look at productivity. We're talking about getting down to that granular level of why am I out in the home today and what is my contribution to keep this individual out of a higher cost center of care. So yeah,
and
maybe if I'm
safe
right and
and
safe, if it,
safe.
right. So if I am working in a facility, I have guardrails that come with this individual being
Hmm.
in a facility. I don't have those in home care. I have to figure out how we collaboratively build them. And that requires at looking at we're responsible for this patient for a period of time, not just when I walk through the door and when I leave, and then I'm basically absolved of you until the next time you come up on my schedule and I'm physically back in the house. And all of this, well, I have to make all these phone calls and then I'm going to have to call this other person. I think some of it, the pushback from clinicians is the visit counting model has made them think doing things outside of a visit is not valuable to the
Exactly.
organization. And I think that's the tone we're trying to change with, kind of poking the bear today to say what we're getting, what we're asking for in
Hmm.
terms of visit focus.
Hmm.
And we've got to start moving that needle, even if it's just in incremental pieces, because this goes back to a different unfiltered productions we did, Sherry, about value-based purchasing. The message of that demonstration project was clear. Their
Hmm.
value for us was not about visits because they didn't save money on home care. Home care costs stayed the same. They saved money by keeping people out of the hospital and out of skilled nursing facilities as a result of their home care experience. If that is not clear of what value is, we now have to figure out how to get that to the clinician level, because too much of it is a wonderful conversation at a conference or a bunch of CEOs and administrators talk about this and wring their hands. But if our frontline nurses, therapists, aides, and social workers don't understand this, we're going to have a big problem in the long run.
Absolutely. And they're going to continually change our payment system to try and get away from opportunities for gaming and
Mhm.
using the simple task of counting. Remember the count. A one. That's a terrible impression, but
I
I
know
did
you.
it
We
again.
should have got the lightning because you always, he had the lightning and thunder sound behind
That's
too when he would
that's
count. So
right. But I
we should
do
have
want to
used.
give a disclaimer, Cindy. I'm going
Yes.
to give a quick disclaimer. We are not saying that visits are not valuable. We are not saying that. We are not saying that cost centers don't need to be managed. We're not saying that. We're not saying that paying a clinician per visit is not the way to go. We don't personally think it is, but that's not necessarily the facts. We're not saying those things. We are just saying that it's time to change our paradigm, time to look at the patient and look at their outcomes first and look at what they absolutely need and what they find to be valuable.
And the final thought I would add to that as well, Sherry, is first of all, fully supporting the disclaimers. I don't want to get nasty emails saying we said, visits don't count at all. That's not what we said. But I think the issue is that we're going to have to pivot because every time we have adjusted our visits, and typically it's been downward, then the next payment methodology says, okay, well, this is what patients need. So this is how we build it. And we reduce again. So it's like we're trapped in a vicious cycle because
Hmm.
we insist that the payment model won't let us do what we think the patient needs. But CMS says we built it, especially PDGM, we ran it with the data of 2018 and 2019. So we took into account that level of therapy utilization. We took into account what you told us patients needed then. Now we get into 2020, well, that had other issues, 2021, and we reduce use. They believe we're doing it because patients don't need as much from us. And
That's
if they
right.
don't need as much, then they're going to pay us less again. So it's almost like we're just trapped in this. At some point, we're in a bad version of that old game show, Sherry, Name That Tune. Are we literally going to end up at some point with, I can see that patient for one visit? I mean, we're doing it to ourselves. And we're part of that problem when we just say, well, I'll fix it by reducing the visits. I'll fix this by ratcheting down the therapy. I'll fix this by, well, then CMS says, oh, look what happened in 2021. Patients needed less care. So if your costs went down and you don't need this, then the next model should just pay you this because that's all you said you needed.
Yeah,
So I think that piece factors in as well as that operational view of if I just keep adjusting my visits downward to accommodate the payment model and maximize my profit, that always just seems to, in the next evolution of payment, get us paid even less.
exactly. Exactly. Thanks to everyone for listening to our rant. Please comment on after you view the video or listen to the podcast and let us know your thoughts. And I hope we made you a little bit uncomfortable at times. That's what we're supposed to do. The only thing that likes change is a wet baby, and we hope to be harbingers of change. We hope to make our place of care in the home, which patients overwhelmingly say is where they want to be, the most valuable, the most desirable place to receive care. Thank you so much.